Thank you for joining us today, and good afternoon, everybody. So, my name's Caroline Bald, and I'm the co-chair of the Criminal Justice Group at BASWA. And it's my absolute pleasure to have David Cochrane, MBE, come and join us today to share everything that he's been learning and what we would like to learn about forensic social work. We will do a presentation from David, and then there's an opportunity to put questions in the chat, or wait and hold on to your questions and then bring those questions directly to David or myself at the end of the session. I really do appreciate people that have shown so much interest and I would say even just admiration for your work, David. That's certainly come across, as hopefully you've been seeing on Twitter. So David's going to be introducing himself. He's going to be talking about his career path, but I just want to highlight, because I think he's Mr. Modest for now, that he was recognised in the New Year's Honours list this year as an MBA for services to health and social care. And I think, flying the flag for social work and doing that in that representation, I think that's fantastic. So congratulations to that. And, I think we'll take that all as a social work win. So I really do appreciate it. But I knew you wouldn't say. So I hope you don't mind me dropping you in it there.
Okay.
No. So what I'm going to do is, if you're happy now to share your screen, and then what we'll do is we'll go straight into the presentation unless anybody has any questions for now. So over to you, David.
Okay, thanks, Caroline. All right, so what I'm planning to do is to just really give a bit of a general overview about the forensic mental health system in England and Wales, and then go on to talk about forensic social work. And I'm hoping to leave lots of time for a conversation with Caroline and others, really. So I'll start off with just a little bit about my biography, as it were. So I've been a social worker for a long time. I did my social work training in Northern Ireland, where I had placements in a probation office, in a inpatient hospital unit, and also I came over to London to do a residential placement in a drugs crisis unit. Then when I qualified, I worked for a while in West Belfast as an education and welfare officer, trying to get kids back to school from truanting. And then I moved to London, where I worked as a residential and community crisis worker in Greenwich. I then worked as a probation officer in a couple of areas of London for a while, and it was there that I had an opportunity to be seconded to Three Bridges Medium Secure Unit for a while. I went back to probation, worked as a family court welfare officer briefly, and then I joined the forensic social work community properly. And I was with West London for a long time, working as a social worker, an approved social worker, and then a manager. And I've also done a lot over the years in relation to training people about a very, very niche area, the social supervision of conditionally discharged patients. So I retired from the head of forensic social work role at the end of June, and I'm now still working with the trust, doing some odds and ends supervising and so on. And I also sit on the tribunal as a specialist member. I'm still on Twitter. I don't know for how long, but I'm still on Twitter, and I retweet quite a lot of material which I think is relevant to mental health social work, forensic social work, and patient safety, because I'm also quite interested in systems issues and patient safety. So that's where I come from. I suppose my kind of professional orientation was, I did a fair amount of training at the Tavistock and the Portman, but I've also done other sort of therapy related things over the years. So that's where I'm coming from. starting off very much in probation and then moving over into forensic social work. So, in my view, is, and we may come back to this at the end, this work in forensic social work is a bit of a hybrid. It's mental health social work, but it's also influenced by learning from probation, albeit that probation is in a very different place than it was when I was a probation officer, for reasons that we all know about. All right, the general system. So some of you will know this already, but broadly speaking, there are high, medium, and low secure services for men and for women. And there have been units called WEMS, Enhanced Medium Secure Services for Women, and they're undergoing some changes at the moment. And there are services for people with primarily a mental illness diagnosis, and for those who have got more of a personality disorder, particularly antisocial personality disorder, verging sometimes into psychopathy. And there are more specialist areas in terms of acquired brain injury, deaf secure services, and there are some services focused on autistic spectrum disorder and learning and intellectual disability. Now, my career has mostly been in mental illness, and I know a bit about the learning disabilities field, but that is not my area of expertise. We've also got increasingly sophisticated community services over the last few years, and I'll say more about that later. But there are these specialist community forensic services across the country, but with also various hybrid models and various sort of quite tricky transition problems when people are ready to move from more specialist services into more generic services. And a lot of money is spent on these services. There are 3 high secure hospitals. There are some 55 medium secure hospitals, and there are 110 low secure hospitals. And then there are these specialist community forensic services, which vary across the country. So there are something like 5,600 beds, which can be categorized as a secure service beds, and a decent number of those are in the independent sector. So NHS services, but also there are various charities and private sector services which deal with people who are on sections of the Mental Health Act which would qualify them as forensic patients. Over the last few years, there's been this system of commissioning via adult secure provider collaboratives. So there are lots of these across the country. The one I mostly work with is the North London one, which covers a range of units across North London. And the idea was that a number of trusts and units would form a collaborative in a particular geographical area with a view to bringing patients back from the independent sector closer to their home and save money and hopefully to improve their discharge pathway, get them out of hospital faster. So those secure, adult secure provider collaboratives are the kind of main overarching services which are sort of commissioning secure services, but with everybody still reporting into the Adult Secure Clinical Reference Group and NHS specialist commissioning, essentially. The specialist community forensic services are fairly recent. Really, since the secure services started, they had, certainly in our service in West London at Three Bridges, there was a time when the inpatient services also followed up people in the community. And that in many ways, that was a nice model. We got to know the patients really well, and then we followed them up in the community. But with the increased size and complexity of services, it's moved more to having separate clinicians of various sorts within specialist community forensic teams. And these specialist community forensic teams were set up really to try and avoid admissions, but also to support recovery and get people out of hospital faster. The idea being that if you've got a well-resourced specialist community forensic team, you can maybe discharge patients a bit faster because you've got the reassurance of knowing the patient and being able to have more ready access to recall or readmission if needs be. And so these are, as I say, well-resourced services which tend to have social supervisors, social workers, community nurses, occupational therapists, psychologists, peer support workers, carers workers, etc. And we'll maybe come back to talking about those in a little while. And this is like a schematic of how they fit within the wider criminal justice framework. Okay, so in terms of what the various services provide, the most helpful material, I think, is from the Royal College of Psychiatrists Quality Network. And there's a particular quality network for forensic mental health services, which really the secure services are required to be part of, and that's a system whereby the Royal College of Psychiatrists have set sort of standards for low and medium secure inpatient services, and services are expected to meet those standards, and there are peer review systems. They're relatively light touch, they're not supposed to be inspections, but there are peer review systems which are designed to help services to challenge themselves and their peers, and to improve the quality of the services. So I'm not going to go into that material now, but there's lots of freely available documents on the Quality Network site, including the kind of standards, but also some aggregated reports from the various peer reviews. So that sets out what the medium and low secure services are supposed to be doing, and a lot of the material which we as social workers are interested in is contained in there, albeit not always badged specifically as social work, but things like carer engagement, patient engagement within the kind of governance of services, etc. Child visits, child safeguarding, adult safeguarding is all feature within this within the Quality Network material. They were last updated in July last year, and as this slide says, that they provide a framework for improving quality in medium and low secure mental health services. So just turning briefly to the legal framework. Many of you will know all about this already, and the kind of quickest way to get a grasp of the restricted patient system is via a publication from the Mental Health Casework section, dated 2017, which sort of sets out how the restricted patient system works and the role of the Ministry of Justice in all of that. But just for brevity, within secure services, we will have a number of patients who are subject to Section 3 of the Mental Health Act, primarily because although they have not been convicted of anything, they represent a considerable risk to themselves or to others, and they cannot be managed within the ordinary inpatient mental health system, and they need the higher level of staffing and security available within low and medium secure services. So we have some Section 3 patients. We have a number of Section 47, 49 patients. So these are individuals who have been sentenced by the courts to prison, perhaps for a determinate or an indeterminate period of imprisonment. But while they're serving that sentence, they become unwell to the point that they need hospital treatment. They're admitted to hospital as restricted patients, which means that the Ministry of Justice have oversight over them, and the doctor's powers are constrained by that. And these individuals will sometimes remain in hospital for a relatively short period and be sent back to the prison to continue their sentence. But sometimes they stay within secure services so long that their sentences end, and they are now classed as notional 37s. They're treated as if they'd been given a Section 37 hospital order. Some of those individuals will remain in hospital and will be considered by the parole board following quite complicated mental health tribunal decision making. We also have a small number of patients who are subject to hybrid orders, Section 45A. So these are individuals where the court feels, the judge decides that there's a degree of culpability and they do not want the individual just to be sent to hospital for treatment. They also want punishment. So the individual is given a 45A, and what that means is they start off their sentence in hospital, and then when the doctors have done as much as they can with the individual, they are sent to prison to continue their sentence and eventually to be released on whatever probation supervision is appropriate. So yeah, there's a handful of those and more as the years go by. So some of these individuals who are subject to Section 3 or who are notional 37s will be subject to community treatment orders in the community, meaning that they can be brought back into hospital relatively quickly without the need for a fresh Mental Health Act assessment. If individuals are subject to Section 3741, which is where the judge sends them to hospital indefinitely because of a risk, because of the risk they present to the public, they remain in hospital indefinitely, but they can be discharged into the community by the Mental Health Tribunal or by the Ministry of Justice agreeing to that. If they're subject to a conditional discharge, then they are liable, they can be recalled to hospital really if they present a risk and their mental state justifies it, and then they're back in hospital indefinitely until they get a fresh discharge by the tribunal or the Ministry of Justice. There's a niche area, typically people with dementia or with significant learning disabilities, where you have a conditional discharge, but you also have deprivation of liberty safeguards orders in parallel. And that's really quite a technical area, which I'm planning to skim over unless people want to come back to it later. So the legal framework is broadly this. Some additions, sometimes individuals will be subject to community orders supervised by probation with conditions of treatment, of psychiatric treatment attached. But these are the main sort of legal frameworks which we're using. We are social workers, as forensic social workers, and I'm just highlighting that there's some useful guidance. It's sort of a relaunch of some previous guidance to support mental health social workers, and AMPS, which came out from Skills from Skills for Care. And the idea of this material was really to help managers and services to understand how mental health social work fits within the wider mental health offer in this country. So I've just mentioned that as helpful background material. There's also some benchmarking material. There's not so much available specifically about forensic social work, but there's a link here to the latest published material, which gives some information about the numbers of mental health social workers and some basic demographic information about them. In terms of forensic social work, we've got a narrower focus within the UK about as to what counts as forensic social work. If you look at the international literature, the academic literature, or if you look at the website of the American forensic social work group, then it's a wider field and noteworthy, really. But for us, what we tend to call forensic social work is social work with patients who have been detained within secure services following a criminal conviction, and then following them up in the community to ensure they get a service in the community, but also to ensure public protection. The most recent documents of note in this area really follow on from the Fallon inquiry, I would say. So those of you who have been around a while will know that within secure services, we tend to flip-flop between being overly punitive and overly indulgent, to put it colloquially. So there was a period where there was concerns about the management of Ashworth Hospital, and there was an inquiry into various very problematic issues within Ashworth called the Fallon inquiry. Social work played a part in that because of concerns that the social worker on a particular ward did not see their role as being as involving safeguarding children as explicitly as they should have. And there was an inquiry into social work in the high secure hospitals called the Lewis Report, and that led on to the creation of national standards for the provision of social work services in the high secure hospitals. And that was published in 2001 and gave us a framework as to what we should be doing as forensic social workers within high secure services. And that framework still is in place, albeit it's still hard. It's now quite hard to find on the internet. But the high secure hospital social work managers still use this as the basic for their work. The funding, the Lewis report was very much emphasizing that social workers should be doing social care work and social work and not be doing therapeutic work. And that was a big theme, really, because of concerns that in the Ashworth Hospital inquiry, there was not enough focus on mainstream mental health and child protection social work. So that document was helpful. We have been trying for years to create something similar for medium and low secure services, and we're just about to put out a document called Best Practice Guidance for Forensic Mental Health Social Work in Adult, Medium and Low Secure Units, Quality Principles. So Daisy Long from DCCI has been helping us with this for years, and Daisy held a kind of final engagement event around this in not long ago, and Daisy's just writing that up with a view to getting that out into the world at large. And that followed on really also from other work that Daisy had done about a capabilities framework for forensic social work, which we did in November 2016. And that's designed to set out really a post-qualification capability framework for people specialising in forensic social work. There's also was a document commissioned by Health Education England, forensic social workers, the role of the social supervisor, continuing professional development, recruitment and retention issues, and that was done by Jacob Daly in 2020. So this is a slide really about Daisy's work, about forensic social work in low, medium, secure service settings. And I can come back to that if people are interested in that. But what do social workers in these secure services actually do? A typical role profile is set out here. I'm not going to read through all the slides that I've created, but it's things like social history work. It's trying to put the patient within their social and family and cultural context. I know we risk stereotyping the doctors and other professionals working within services, but from a social work perspective, we want to provide a holistic view and not just focus on a narrow clinical diagnosis. We want to think more widely in terms of a psychological formulation and a social psychological formulation, thinking about where somebody comes from, their family of origin, their community, their cultural background, and so on. So we are trying to provide that within the clinical teams that we're working to help other clinicians to understand the housing that somebody may have been living in, the sorts of community that somebody comes from, because there's always a risk that that the clinicians are so focused on the day-to-day clinical interactions that we lose the wider social context. We are spending an enormous amount of time these days on sorting the responsible local authority and 117 issues. Lots and lots of squabbles between local authorities, particularly in London, about who's got responsibility for funding Section 117 aftercare. But we are trying to maintain links with whichever community services are going to be following patients up in the future. That has become increasingly difficult in recent years because of the pressures that local services are under and their inability to provide a sort of through care service, which we think they should be providing, so that the patient continues to know that somebody in their home area has them in mind. Our work is very much to do with getting information from families and carers and other agents other community agencies who've known the patients, as part of developing an overarching risk assessment and risk management plan, and trying to focus early on the discharge pathway, trying to make sure that people's length of stays are reduced as much as possible. We do a lot of report writing, doing reports for tribunals, attending tribunals and managers' hearings, and giving evidence. Sometimes we're involved with the parole board, with transferred prisoners. We're taking a lead in child and adult safeguarding within teams. Typically, the social workers should have added skills and expertise and knowledge in child and adult safeguarding, and we tend to take a lead in those areas. We take a particular lead within services around carers contact. There's lots of concerns from forensic carers about their involvement in services. Many are highly critical that they feel left out by services. There's a document called the Secure Carers Toolkit, which services are supposed to use, but often they don't really know about that document, and it has its limitations anyway. So there's really some quite complicated work which we try to do with individual carers, and in terms of hosting various carers forums within services. We ought within social work to be leading on equality and diversity issues. Increasingly, other disciplines within secure services are also very concerned about those matters. So in my service, we've got a number of nurses who act as leads, but we are trying to promote those anti-discriminatory practice issues, which have always been core to social work. We do a lot of work with MAPA and with victim liaison services, and increasingly in the kind of niche area of extremism and terrorism. We sometimes do appropriate adult work. If we're working in the community, we do social supervision, which is acting as the social supervisor and reporting to the MOJ about the patient's progress on a frequent basis. Some colleagues within services are also AMPs. Forensic community work. So I've talked mostly about inpatient work, but there are these specialist community forensic teams, but there are also forensic social workers who are not within specialist community forensic teams, but who work for the local authorities, or who work in generic mental health services. There's a fair amount of work going on at the moment to develop social supervision. I've been involved with Jack Tomlin, who is on the call, and others in developing training materials, commissioning a literature review, and just generally trying to increase the profile of social supervision, which is, as I say, where we are following people up after a conditional discharge. This is a successful system in that we we have to follow people up closely. We do follow people up closely. We report to the MOJ, and we can recall via the MOJ the individuals to hospital for treatment very quickly, and that really serves public protection in a significant way, which means that there's very low serious reoffending rates within this service. I can tell you more about this work, which is still not all published, and one of the outputs is some material which hopefully will be published by ADAS, which is a kind of a framework really among primarily to educate senior managers within local authorities and other settings about the responsibilities that they are actually carrying, sometimes responsibilities which they don't quite know they're carrying with respect to high-risk patients in the community. So, forensic social work, interesting, really rewarding work. I think we're working at the intersection between the mental health system, dealing with people with learning disability and autism, severe mental illness, severe personality disorder. So we need to know about mental health in terms of inpatients and outpatients, but we also need to know about the criminal justice system, how prisons work, how probation work in the community, and this is such a changing environment just at the moment. It's really hard to keep up. We also have to know about social care systems, because we are needing to refer for Care Act assessments. We are needing to get 117 responsibilities sorted out so that patients have got proper provision in the community. So we need to know a lot of different areas, which makes it really interesting. And in my view, again, we might want to discuss this. I think we need to know about social policy. We need to know some sociology, some criminology, and we need to know about criminal justice perspectives. And we need to be bringing that into the inpatient hospitals, where the clinicians have got a different orientation and a different training from us. There's technical expertise we need in terms of tribunal reports, 117, particular aspects of the Care Act, particular aspects of around parole, and so on. And there's lots of technical issues really about how we apply the Human Rights Act within these services, rights to privacy versus rights to right to life and public protection. It's also a really interesting area just because of the complexity of the offending. So we're working with individuals who have committed homicide, sexual offending, extremism, fire setting, etc. We're doing family work and carers work, often over extended periods, with family members who are distressed in various ways and traumatized in various ways. We're leading on MAPA and victim liaison. We're often in contact with the mental health casework section. We're leading on safeguarding, but with a particular emphasis on safeguarding within closed institutions and on institutional abuse and risks associated with closed institutions. And we are holding a medium to long-term perspective on these patients. And we're working very much in a relational way, in old-fashioned social work, where we get to know the patient and their families very well over an extended period. The work is also very interesting and challenging because of multidisciplinary teamwork, power issues, team dynamic issues, which are just pervasive in these settings. Whose views prevail? How do we get a social work perspective into the mix? And if we're working within the NHS, then there's various NHS opportunities for research and for quality improvement initiatives, and also some opportunities in relation to developing therapeutic skills, which, as I say, have been downplayed quite a lot in the aftermath of the Lewis report and the national standards. So I'm about to finish. How does one become a social worker in the forensic world? Well, lots of social workers employed within the NHS, some employed within the local authority. Uh, Within our service in West London, we also employ as social supervisors in our community services some people with a probation background who are not registered social workers. It's quite tricky because we have to be careful not to call them social workers, and there are substantial career development issues in that they reach a bit of a dead end sometimes because they cannot do social work advanced trainings because they're not social workers. But nevertheless, if some probation officers do work with us for a while and then maybe move back into probation or move into other areas. The landscape has changed. In the old days, we used to take people who had substantial experience as community social workers in mental health. Those days have gone, and we are now increasingly taking much less experienced people. We are encouraging placements, social work training placements in our service in West London. We're also linked in with Think Ahead. We have a number of Think Ahead trainees with us at the moment. We also sometimes take social work newly qualified social workers through other routes. The banding varies in different services in terms of the NHS. So many of the social workers are band 6, but there are also other opportunities, and there are likely to be opportunities in terms of apprenticeships in due course. And these services desperately need staff. So if you know of social workers who are interested in, there's various routes in, and hopefully also out again, because I know I'm a bit controversial. It can sometimes be a bit unhealthy to stay within these services for years and years. It can sometimes be better to work within inpatient services for a while, then maybe do something else, then maybe come back again at a higher job level or whatever. It's just important that we don't have closed institutions. We have people coming and going, and we bring in new skills. There's some national forums. There's a national group for social work managers in secure services, and there's also has been an ADAS forensic network group, although that's morphing at the moment. And again, if people are interested in that, I can tell you more. So my contact details are there. As I say, I am on Twitter, for better or worse, and I think I'm going to stop there, Caroline, and I think I'm going to stop sharing. It gives us 15 minutes.
That's wonderful. Thank you, David. So, I mean, there's a lot of food for thought there. And just on that point about, staffing and the workforce development, I've certainly had a number of students say that they want to go into forensic social work, and it's not as clear a pathway, but also there's not so many placements. I was lucky to get a placement with a student who's now gone on to work with yourselves, but they're few and far between. But I've also seen increasingly students, maybe because it's within my earshot, wanting to be know more about the criminal justice service. And I've been really concerned, and I know a few of you here, like Diane's heard me bang this drum before, about the separation of the educations. I think has had a significant impact on social workers' understanding of criminal justice. So I really do appreciate you saying this, sharing everything you've done. You're going to, from this conversation we're about to have, we've got one question at the moment, more of a technical question, I think, but probably belies a whole conversation itself. Please do ask conversations. You can either put your hand up or you can put it into the chat. So if I come on to, so a couple of comments. So there's a current, so Rowena, thank you. There's a band 6 social work post currently at Ashworth. If anybody knows of colleagues who might be interested, so that's something we can share. Thank you. And also, Jade, you've asked a question. For those on an Irish High Court order, what rights do they have for hearings? As I'm aware that there is a court review, but there aren't managers' hearings or tribunals. Is that correct?
I don't know about the Irish mental health system. I've got a colleague who I can put you in touch with, but that's not my area of expertise.
That's wonderful. Thank you. So I think Gary had his hands up, and then Nick, you've got a question. So if I come to you, Gary.
Thank you, Caroline. First of all, thank you, David. That was a really good presentation. Thank you very much for that. If I can just ask, will there be some inclusion of the independent sector? As you know, I'm from Elysium Healthcare. We obviously have prior in Signet. So I just wonder what your thoughts are on that, because obviously it's not all just about NHS, local authorities, etc. There is a large number of hospitals, forensic settings, which are, provided by independent providers.
I did mention that at the onset, Gary. That's right. And I know that the work which Daisy Long is finishing off. Daisy's had representations around the wording of some of the material which she's working on at the moment. But you're right. It is quite hard to generalise about, because in different areas and different hospitals, the social workers do slightly different things.
Thank you, David. Appreciate that. Thank you, Caroline.
It's a really good question, thank you. And it's interesting seeing parallels across other areas of social work as well. I think when you were talking about carers and working with carers, certainly in the work that I've been doing around ABI and brain injury generally, again, it keeps coming up that carers aren't fully embedded in the work we do. So Nick had a question. I've been told that there is little career progression within forensic social work. Do you agree?
I don't think I do. I suppose it sort of depends upon the size of the service. So there will be some quite large services which will have band 6 social workers, but also some band 7 people doing supervision, and probably a band 8A person who's a team manager. So there's certainly opportunities in terms of band 7s, and the banding does vary across different trusts. Some services tend to have many or most of their social workers at band 7. So there's opportunities in inpatients. There's also lots of opportunities in outpatients for band 7 people acting as social supervisors and supervising other less experienced colleagues. So there tend to be jobs within SCFTs, and now that many of us are employed by the NHS, there's also some opportunities to move over into general management in terms of getting roles which are open to nurses, occupational therapists and others at higher bandings and going up through the management system. So within my trust, for example, somebody who came in for a while as the head of social work in local services, then moved over into probably an 8D type. I don't know what grading it is, but a high overall sort of local services management job. So I think there are opportunities. I would say.
That's really helpful. I particularly liked when you were saying about moving, the benefit of moving in and out of different settings. So I often get the impression it's a very interesting but separate career ladder that you can go in so many different ways, pretty much like the work that we were doing in probation.
I think that we learn such an enormous amount within inpatient services about such a load of things that we can then move out again into the community and to do other things. But that's my view.
No, thanks for that, Nick. We've got a rather specific question from Samantha, and then I know, John, you've had your hand up a wee while, so I'll come to you next. Will there be more social supervision trainings running? So in West London NHS?
Yeah, there are various providers who do social supervision. Obviously, I do it. If people want to email me, I can sort something out.
Fabulous, thank you for that. And over to you, John, for your question.
Thanks. Thanks, Baswa, for facilitating this. Thanks, David, for the kind of presentation. We were late joining the call. Apologies for that. But I do know you're coming to talk to the North East AMPs during our next kind of refresher session, so I'm kind of selling that to AMP colleagues. It was a very specific question, and I've heard you talk about the kind of almost the siloing of kind of forensic skills. And I heard you mention the network opportunities. You talked about the ADAS network, yeah. The ADAS, and then I think you said it was on hiatus or it wasn't running at the moment. So I just wanted to clarify kind of what opportunities there are nationally, and then just to kind of say to colleagues on the call and wider that if anybody kind of wants to share anything or wants to kind of collaborate in conversations, meet up on Teams, I'm kind of welcome with that. We're from Gateshead, which is a fairly small semi-rural, and I've brought the forensic social worker with me, who's Dominic, and it's quite a lonely furrow that he ploughs most days.
Okay, so this is all a bit in flux. So there has been a group which has been hosted by Richard Pryor, who's the social work manager at Froomside in Bristol, and that's the national group for social work managers in secure services, and that has met online and face to face. And that has primarily been the managers from inpatient secure services. There's also been an ADAS group, which has been more focused on community and local authority and social supervision. And it's likely that those two groups are going to morph into something else, but we're still in discussions around that. So I think the narrowest answer is I'm probably a bit like the spider in the spider's web. I probably know about these networks. So if you just email me and network with me to start with, I can try and point you into to various directions. I saw the point, the comment about forensic social work being where social workers go to die. I just think that's really unfortunate. The thing is, we like it so much that we stay a long time because we're doing social work and we like it. So yeah, some people do stay a long time, and there are concomitant risks, professional risks, which I've described. But we like it, and we do a good job.
No, with you on that. No, with you on that, and I think you hear that too often. And it's particularly when workforces are so unstable, to have people actually stay and gather knowledge over a period of time, you would think is a strength. So Yusuf, and then I'll come to Tendai. Yusuf, I think you've got a very specific question. So not sure if section 4849 was considered. Also, what are your views on restricted patients accessing social welfare benefits? Controversial.
Okay, so I didn't include 4849. So there's other sorts of transferred prisoners which can be considered. And I suppose all I would say is 100 Families. Julian Hendy from 100 Families, whom I know well, and does a strong job in terms of advocating for the victims of mentally disordered offenders. Julian has got strong views about welfare benefits and so on. I mean, I think my own view is it's quite complicated in that we want people to have opportunities for rehabilitation, and so I think it would be unfortunate if all benefits were removed. But clearly, there are strong feelings around this area. For very understandable reasons from victims' perspectives.
Yeah, no, thank you for that. And so we're conscious of time, and I take your point, John. This needs more conversation, more time. So it's a pleasure to put this on, but let's find another space that we can gather. Tinda, you've got your hand up, so I'm happy to pass to you for the final question.
Yeah, thanks so much, Bob. Thanks so much, David. I just wanted to ask for your thoughts, especially in relation to the recent news with the Nottingham murderer and the potential impact that might have in terms of recruitment and retention. Because I think it's quite easy to sink into the narrative that, services are disjointed, then there were missed opportunities, and the impact that might have to stuff like the forensic social work.
I mean, this is all so raw. It's really very, very difficult. I watched the Panorama program. I've glanced at the CQC report and obviously seen the multiple criticisms about the CQC report in terms of lack of understanding of 117, etc. I mean, Falcone was not under forensic services. I don't know where this is all going to lead. Certainly, Anton Eldergill, who's very experienced professor in this area, just recently sort of stopped being a kind of judge in the Court of Protection. Alan Sim's line is, everything is so fraught at the moment. Really, it's not a great time to be making legislation. They ought to step back and to consider more professional perspectives and not just rush ahead with a new bill. And I think there are major issues around recruitment and retention of doctors and other disciplines, which potentially are only aggravated if we focus on blaming individuals. The whole thrust of the current patient safety movement and HSSIB and so on is on a systems approach and on providing safer systems and not just targeting individuals when terrible things happen.
Thank you for that, David. Thank you for everybody for joining us. I appreciate it. It's only an hour, and I think we could have had this conversation the whole day, if not more. So if this is of interest to people, I know criminal justice, social work in England, people not quite sure what we do, but we look at prisons, probation, social work, mental health, anywhere that it comes in contact with criminal justice. So please be a member of that if that is something that you'd be interested in. We're meeting straight after this event, so if you'd like to stay and actually see an agenda and get a sense of who's there, you're more than welcome, but we also understand people need to leave. So thank you very much, David, again. David Cochrane, MBE, well deserved. Really appreciate you spending the time with us today, and thank you for everyone for joining, and watch this space for another event. So take care, everybody. Thank you for coming.
Thank you very much.
Thanks, Nick. Take care. Bye, Gary.
Thank you.
Bye, John.
Thanks,
Bye.
everyone.
Take care, everyone.